I think it's important to know where your speaker is coming from. Many of your speakers you know very well. I was a cardiac surgeon at Georgetown University for 20 years. I directed the heart transplant program. And then after 20 years, I focused on critical care and moved to George Washington University. And now, last 5 years, I've been at Johns Hopkins University. I started an international conference related to cardiovascular thoracic critical care, and we are now planning our 12th annual conference. I've also been the AATS ICU director of the ICU of the Future and a co-director of the postgraduate courses for our two large organizations. And probably most important, and I value this position, is I'm an associate editor for the Journal of Thoracic Cardiovascular Surgery for the section of perioperative management. So I have the opportunity to get a view of the latest thinking and the latest studies that are being performed. As I say, I'm at Johns Hopkins Hospital. We have a dome, and this is the new clinical building. This is our ICU, and my topic is incidence and outcomes of acute kidney injury and cardiac surgery. AKI has long been recognized as a relatively common complication of cardiac surgery. When it occurs, the risk of mortality is greatly increased. And renal failure after cardiac surgery, AKI, occurs in medical centers around the world. The clinical issue is recognized worldwide and has become known as cardiac surgery-associated acute kidney injury, and we all refer to it as CSA-AKI. The fundamental situation, though, has not changed. And so even though my topic is, as you know, incidence and outcomes, I'm going to spend a short time reviewing latest data because, frankly, it's not very different from what we've had. I believe we need new directions to address the long-standing and new challenges of cardiac surgery-associated AKI, and that's where I'm going to spend the majority of my time. Well, the risk factors for AKI are well known. There's a study group from Milan that looked at 5,068 consecutive cardiac surgery patients, and they found, and they referred to this as acute renal failure, 3.4% developed it, and 1.9% needed renal replacement therapy. Look at the mortality, 40%, 41% hospital mortality if cardiac surgery patients develop acute renal failure, 64% if renal replacement therapy was required. And when they did a multivariate analysis, you can see the usual type of risk factors. For cardiac surgery patients, blood transfusion, creatinine greater than 1.4, emergency surgery, reopening, low ejection fraction, mitral valve disease, need for an intra-aortic balloon pump. And if you look at the patients who required renal replacement therapy, it's the same basic group. Blood transfusion, emergency surgery, creatinine, reopening, mitral valve disease, duration of cardiopulmonary bypass. The incidence and mortality of cardiac surgery, well, there have been many studies over the years, but I think we all have a great deal of appreciation for not only the cardiac surgery, but the nephrology at the Cleveland Clinic. And this was a study published in 2007 and relates two periods, 1997, 1993 to 97, and then an updated period, 98 to 2002. And you can see that the incidence of AKI had increased from 5.1 to 6.6%. The mortality, and again, this is an excellent center, we well know, for nephrology, had been able to be decreased from 32 to 23. But if you look at the mortality related if renal replacement therapy was required, it actually was, even though it had gone down, it was roughly 50%. And I can tell you from our experience that this has really not importantly changed. Here is an update in trends in AKI and cardiac surgery published from Stanford University, Annals of Thoracic Surgery, 2013. This is 8 million records reviewed. And the inpatient mortality, although it's gone down, is still 13%. And if renal replacement therapy is required, it's 35%. The effect of AKI on long-term survival after cardiothoracic surgery has been well described, and these are curves I think that many of you've seen in circulation, and this is the Rifle criteria, but clearly if failure develops, survival at 10 years is very importantly impaired. And then, of course, we have the new government reimbursement policies, the Affordable Care Act. And it's value-based quality health care. Value and quality are determined by outcome data, and that is mortality, length of stay, and complications. And centers are either rewarded or penalized if they have, according to their outcomes. And we well know that CSA-AKI impacts patient outcomes in these important areas: mortality, length of stay, complications, and, for example, lung failure, infections, and other complications. Now, Dr. Ronco's international conference are about developing and sharing new ideas to advance patient care. So you can see I've spent 6 minutes on my topic. And so what I want to do is take the new directions, because I think that's where we need to go. These conferences, and ADQI is a great example, but these conferences are true think tanks to advance patient care. So in this spirit, I've changed the emphasis of my presentation to new directions to advance patient care for CSA-AKI. I think we need new directions, clearly. The key issue in cardiac surgery patients is the adequacy of organ perfusion. A fundamental issue during cardiac surgery and postoperatively are the ongoing hemodynamics causing AKI? Are they causing it? And if so, how severe is it? What is the trend? And how can changes in management be monitored to know if we're getting the patient better? Now, the other part of this is the expanded challenges in cardiac surgery. And if those of you who admit cardiac surgery or consult on them know that there's an increased acuity of patients, increased complexity of procedures, and now with coagulopathies, particularly an important complication, a need for open chest protocols, and there is new supportive technology. Open chest protocols are used in complex situations such as continued bleeding, coagulopathy, marked mediastinal pulmonary edema from prolonged cardiopulmonary bypass time, shock states preoperatively. So emergency Ecmo and temporary VADs are very common. And the open chest, here's an open chest. This patient has undergone cardiac surgery, but they could not close the chest because the heart would be compressed by accumulated blood or by edema. And so the ICU open chest has important issues, and one of them is optimal renal perfusion. Another is volume overload. These patients are volume overloaded, and these patients are on mechanical ventilation and sedated, so we're concerned about sedation, analgesia, effect on hemodynamics, and cerebral perfusion. Ventricular assist devices are now becoming more and more employed. Preoperative patients who are admitted with preoperative severe congestive heart failure may have a bad place. A preoperative MI and cardiogenic shock, a bad place. If a patient is having an operation, cannot be separated from cardiopulmonary bypass, they are certainly a candidate for a VAD, and postoperatively they may receive a VAD. Here is a VAD, and they're both permanent or implantable VADs and temporary VADs. My early experience was with the temporary VADs, but now we have implantable ones. Hemodynamics, I've created actually a hemodynamic simulation for training people in VADs because it's complicated. You see, the right ventricle, of course, is not assisted. So you've got to focus on the VAD and the LV, and there's some very important mechanical issues. And VADs and AKI is a frequent occurrence, and it's an important factor in the patient outcome, as we've talked about, mortality, length of hospital stay, and long-term. I'm happy to say that the Vicenza group, Dr. Ronco's group, and I'm working with them, we have published on this subject, and we call this VADs and the kidney, and I refer you to these publications. They are basically a review of this important topic. Ecmo. Extracorporeal membrane oxygenation. There's an increasing number of patients who are now candidates for Ecmo. Cardiac surgery cases unable to separate from cardiopulmonary bypass, acute MI, cardiogenic shock, acute respiratory failure, ARDS, pneumonia. You know the H1N1 situation, and resuscitation cardiac arrest. There is an important association of Ecmo with AKI, and I'm happy to say again that the Vicenza group has a review that is in its final stages, and Gianluca Villa and a group of us have put this together, and we look forward to your being able to review it. Here is Ecmo, and it's very commonly used with renal replacement therapy. And optimizing hemodynamics on Ecmo is complicated because these patients tend to have, as we call it, vasoplegia. It's very important to make sure they have adequate renal perfusion, and volume overload is very much a problem in these patients. So cardiac surgery also has, critical care has confounding factors. So those of you who know our literature know that there is a concern about avoiding blood transfusion, because if you avoid blood transfusion, data suggests you may decrease acute lung injury, decrease infections, and maybe decrease AKI. But the problem is, if you run a low hematocrit, you have the increased need for vasopressors, and we are not able to monitor renal blood flow. So frankly, we don't understand exactly what we're doing if we run a low hemoglobin and have patients on pressors. So what criteria in real time do we have to determine the optimal balance of hemoglobin and vasopressors? Over the years, progress in reducing cardiac surgery AKI has been impeded by two major factors: a lack of biomarkers for immediate recognition of kidney injury. We didn't know what happened because the pump prime dilutes the serum, and so we don't know that the creatinine may have risen for 48 hours. We miss it. And biomarkers, the evolution in biomarkers is tremendously important. And we've had a lack of technology to monitor blood flow to the kidney. So let's just quickly say about the biomarkers. This is going to be very well covered. I first learned about biomarkers at our conference back in 2010 and think it's started a new evolution in our understanding. And this will be well reviewed, the importance of NGAL and its early that it appears very early and can be used for an early institution of therapeutic changes. And of course now we have the cell cycle arrest biomarkers, which are an important advance and I believe should be used basically in virtually all cardiac surgeons to understand the stress to the kidney. Over the years, the progress has been very importantly impeded by a lack of technology to monitor blood flow to the kidney. Ideally, we would like to know renal blood flow. That would tell us a lot, especially patients on cardiopulmonary bypass or in the ICU on vasopressors, but it is not available. So what do we have? Well, minute-to-minute urine output can be used as a surrogate measure of renal blood flow. It's not perfect, and obviously a patient has to start with urine output, but it can be used, and you've seen some of the data already to suggest that urine output is an important parameter. Here is our current hemodynamic technology in the ICU. Look, there is a VAD there, there's a balloon pump, there's a ventilator, there's monitoring. Where do we stand with measuring urine output? That's where we are. That's how we do it. This is the Johns Hopkins ICU. And if we want to know what the urine output is in the shift, we drain it into a graduated cylinder. Urine output monitoring technology is important and needs to move from ancient times. This must be the way they did it in Greece and Rome to the 21st century. What are the directions for technology development? Well, there is electronic minute-to-minute urine output. It needs to be integrated with the monitoring systems for the operating rooms and ICUs, and we need alert systems with that to alert the staff to important decreases in urine output. There is such a system. This was the FlowSense system, UrinFlow. This was a system developed. We actually used this system at Johns Hopkins, started to use it, found it very valuable, and some of the data shows a drop in urine output could be associated with a drop in blood pressure. There are important correlations. So we connected it to over 50 patients before the system became unavailable. It worked well. We had it integrated into the ICU. There is alternative technology, the Renal Guard system, and the BARD critical core monitoring system. But unfortunately, the info system was taken off the market by the company. Unbelievable. And so my school, Johns Hopkins, not my school, Johns Hopkins School of Biomedical Engineers, the master's students came to me and said, we would like to study and design a biomedical device to address the need that you have for your research. So they have called it Renal Alert, and developed by the biomedical engineering candidates. Here it is. We've just filed a patent for it. And as you can see, I'm one of many advisors. One is Derek Fine, our nephrologist. Very important are the ICU and the nursing and the academic and the engineering advisor, Dr. Karya. And this is the solution: real-time urine output, automated urine sodium, and algorithms to integrate with critical care monitoring. So we have done, we have a research team. When I arrived at Johns Hopkins, I created a research team of nurses, intensivists, surgeons, anesthesiologists, nursing staff, and our data analysis people. And this paper I recommend to you. This was put together by our group. Blood pressure excursions below the cerebral autoregulation threshold during cardiac surgery are associated with a risk for acute kidney injury. See, this is now starting to understand how hemodynamics impact AKI. And it turns out, as I told Chuck Hogue, who is our senior anesthesiologist, I said, Chuck, you know, I think the kidney thinks like the brain. It probably does have an autoregulation threshold. It's probably different than the brain, but in fact, we need to understand the relationship. So in fact, if you look at this, the one p-value that's very important, you notice that urine flow on the vertical axis, and patients without AKI, it's somewhat similar, pre-bypass and on bypass, but post-cardiopulmonary bypass, there's an important difference in urine output. And these are the patients who, by biomarkers, had AKI. So let me have just a few moments to update you. We now have a manuscript in preparation. I received it on the plane, and I have downloaded just a few points. This is urine flow rate during cardiopulmonary bypass as a monitor of renal perfusion and risk predictor for cardiac surgery-associated AKI. Dr. Hori from Japan and the whole group, and Dr. Hogue there is the senior investigator. This is based on an NIH study of cerebral preservation, and I've integrated our AKI study into it. And you can see that this is 563 patients, 50 consecutive patients using the photoelectric urine flow device before it became unavailable. Cardiac surgery-associated AKI developed in 30% of patients. Remember, these are in a cerebral preservation study, so these are patients with a fair amount of vascular disease, tend to be older, and we know have a higher risk of AKI. So it's a very good population to study. And we found that those patients with CSA-AKI had a lower urine flow rate during cardiopulmonary bypass than those without. And the urine flow rate was independently associated with blood pressure excursions below the optimal blood pressure or the cerebral autoregulation threshold during cardiopulmonary bypass. And logistic regression studies showed basically the same thing. So it's very important, we believe, to monitor urine output and understand its relationship to the cerebral autoregulation threshold, which we study in the operating room with a near-infrared spectroscopy NIRS. We actually designed a protocol and presented it to the company that had the urine flow device, and the scientific advisors recommended that we were all set to go ahead when suddenly the company decided to take the device off the market, and we could not perform the study. Needless to say, we were very disappointed. So our hypothesis was early institution of hemodynamic interventions based on minute-to-minute urine output and near cerebral oximetry will reduce the incidence and severity of CSA-AKI. We developed protocols based on this data. So I think I'm right at my time, And I thank you for the opportunity to present this. As I say, one of the reasons is this conference has always been a sharing of ideas for advancing patient care in the future, and I hope this is helpful, and I look forward to sharing ideas with you all. Thank you very much.